Good afternoon. It's very much our pleasure to be sharing our talk today entitled Orientation to the Science of Dissemination and Implementation. We want to start by thanking the folks who made this possible today. We want to thank Sarah Birkin, Rebecca Seelove, Sarah Bernal, David Chambers, and the NCI for this great idea and for giving us the opportunity to present today. We'll start by giving you a sense of what the objective of this talk is, which is really to give a broad overview of the field of implementation science. So it's going to be a survey, and we have prepared a resource guide which will be paired with this talk on the website, which will give you additional resources if once you drink the Kool-Aid, you decide you're as interested in implementation science as we are. We also invite you to follow us on Twitter for the latest happenings in implementation science. I'm just going to start with very brief introductions of myself and my colleagues who will be speaking today. So I will start. My name is Rinad Beidas. I'm an associate professor of psychiatry and medical ethics and health policy at the University of Pennsylvania. I'm joined by Dr. Cara Lewis, who is an associate investigator at Kaiser Permanente Washington Health Research Institute, and also Dr. Byron Powell, who's an assistant professor of health policy and management at the Gilling School of Global Public Health. Dr. David Chambers, who's the Deputy Director of Implementation Science at the National Cancer Institute, will also be joining us today and will be asking us some questions about the field. Very briefly, this is the overview of what we hope to accomplish today. So we'll start by giving you just a very big picture and introduction to the field of implementation science. Dr. Lewis and I will provide two case studies from our ongoing empirical work that we'll try to infuse throughout the whole presentation. Then we'll discuss implementation frameworks and process models, and we'll talk about how to identify and prioritize barriers and facilitators to the implementation process. Then we'll talk about implementation strategies and tests of implementation strategies, evaluating your implementation efforts, and we'll have some time for discussion and question and answer at the end. So without further ado, I will pass it on to my colleague, Dr. Powell.
Thank you, Rinad, and hello, everyone. Just by way of foundation, we know that we have a lot of challenges in translating research into practice, and this is a figure that's drawn from Beidas and Byron in a study that's now almost 20 years old that really depicts that moving from original research to patient and population health impact takes a lot of time. So by the time we conceptualize our research, submit it to funding agencies, and then later get it obviously published in peer-reviewed journals, hopefully into bibliographic databases, and then subsequently into reviews, guidelines, and textbooks where it's often picked up more widely, it takes a great deal of time. So Beidas and Byron really illustrate the sort of the leaky pipeline here, and demonstrate that it takes 17 years to turn 14% of original research to the benefit of patient care. Again, this is an old study, but I'm told from colleagues at NCI that this is being actually replicated in a more recent study, and that we haven't gotten much better at moving research into practice. This really forms the foundational argument for implementation science. We've all heard the adage from bench to bedside that we would hope that basic and clinical research is turned into the benefit of patient care, and what we often see is really from bench to bookshelf. This is really well documented in a number of key reports from the Institute of Medicine. So this To Err as Human report, I think, was published in 1999. And then recently, the National Academies published Crossing the Global Quality Chasm that demonstrates that these gaps between what we know works and what we actually do in routine care settings are still enormous, and that we have a lot to do to introduce evidence into practice. So dissemination and implementation science has really been prioritized, certainly in the US and internationally. This is a very US-centric slide, but demonstrates that for the NIH, AHRQ, national academies, and a number of other federal institutes and private foundations, implementation science has become a big priority, demonstrating in particular, that we spend a lot of money on basic and clinical research, but we spend far less on understanding how we can actually translate the findings of that research into routine care. So we define, or I should say, the NIH program announcement on D&I defines dissemination research as the scientific study of targeted distribution of information and intervention materials to a specific public health or clinical practice audience. So the intent here is really to understand how to best spread and sustain knowledge and the associated evidence-based interventions. And the program announcement defines implementation research as the scientific study of the use of strategies to actually adopt and integrate evidence-based health interventions into clinical and community settings, ultimately to improve patient outcomes and benefit population health. These are sort of another set of related terms that you often see in the literature. So we see diffusion from Everett Rogers' work on diffusion of innovations, dissemination and implementation. And perhaps in a more straightforward way, we can think about diffusion as really letting it happen, letting innovations become routinely used over time. Dissemination is helping it happen, and implementation is making it happen. So we want to acknowledge at the outset that implementation science, dissemination and implementation science are influenced by multiple fields and disciplines. Really, we've begged, borrowed, and stolen from a lot of interesting places, including improvement science, intervention effectiveness and process research, healthcare, behavioral economics, medical anthropology, social psychology, and organizational and management. And these are just really a smattering of the areas that we've borrowed from. So as you move forward in this field, it's often fruitful. And in fact, my colleagues may share some examples of ways in which they've drawn from behavioral economics and other fields in their work. So this just demonstrates one translational pipeline model that I think is useful in thinking about implementation science. And so we can think about some of our basic and sort of pre-intervention work, and then how that leads into efficacy studies that are highly controlled and are really designed to tell us, could an intervention work? And then moving to more real-world effectiveness studies, where we have a little bit less researcher control, and we're really trying to answer the question of, does an intervention work? When we move into dissemination and implementation research, we're really trying to think about how we can make an intervention work in real-world settings of care. And in this upper right-hand purple box, you see that implementation is often conceptualized in multiple phases. So starting here at exploration, preparation, implementation, and sustainment. This is drawn from Greg Aaron's EPIS framework. We see that sort of the iterative and multi-phase nature of implementation science. And this box also demonstrates implementation practice and implementation research. And so you can see implementation practice focusing much more on local questions. Can we make this intervention work in this specific setting? Whereas implementation science or implementation research really focuses heavily on developing generalizable knowledge, and can we generate some methods and procedures that will work across settings and disease conditions. Another way of thinking about this effectiveness versus implementation question is that in much of our effectiveness research, we're really focusing on evaluating health outcomes and focusing on the intervention that we're trying to implement. Whereas in implementation science, we're really focusing more on the system to support adoption and delivery with fidelity. So evaluating outcomes related to the quality, quantity, and speed of delivery. This is yet another model. This is drawn from Enola Proctor and colleagues that demonstrates sort of our usual way of thinking about clinical and effectiveness research, is that we're focusing on the what. So sometimes specific interventions, innovations, or evidence-based practices, and really focusing on the health outcomes. So satisfaction, functioning, and health status and symptoms. So that's sort of the usual. Implementation really focuses on a different set of outcomes and also a different set of interventions. So we'll talk today about implementation strategies, which are really the how of implementation. And we'll also talk in a little bit more detail about implementation outcomes, but these are the sort of intermediate indicators that implementation is successful. and they help us differentiate between intervention failure and implementation failure. So things like, are interventions acceptable, appropriate, feasible? Can we get organizations and systems to adopt these interventions with fidelity? Can we look at things like penetration or reach over time? So the proportion of clinics or clinicians that are implementing a given intervention, and then ultimately, can we sustain and scale up these interventions? So that's really the core of implementation research and much of what we'll focus on today. In much more plain language, we're drawing from our colleague Jeff Curran here. We can think about the intervention, practice, or innovation as the thing. We can think about implementation strategies as being the stuff that we do to try to help people and places do the thing. And then when we think about implementation outcomes, we can think about them as really helping us understand how well individuals, organizations, and systems do the thing. So we can move on to questions for this section.
Thanks, Byron, for getting us kicked off. A lot of people come up to us and they say, I'm still struggling to see the difference between the implementation study and the effectiveness research study. And you talk about the thing, they may look at their outcomes of their effectiveness study and they may say, but that's also, I'm really focusing on how well we do that thing. I wonder if each of you might be able to just give us a little bit more, more guidance on how do we make that distinction between our effectiveness research and our implementation studies. When you look at these sort of two studies side by side, are there other things that help you either put it squarely in the implementation bucket or squarely in the effectiveness bucket? Anyone?
Yeah. So one of the first things I'll say is that oftentimes with implementation studies, there's much more, again, focus on the implementation strategy. So evaluating the interventions that we're actually using to get the clinical innovation or intervention or the thing into practice. So oftentimes we're really focusing on, are those strategies acceptable, feasible, and appropriate, and do those actually lead to improved fidelity of the clinical intervention? The other thing that I can just point to that's to kick us down the road is that we're increasingly seeing this sort of blur between effectiveness studies and implementation studies. And so we'll talk down the road about hybrid implementation or hybrid effectiveness implementation trials and sort of different ways of conceptualizing that. But maybe Cara and Rinad have additional thoughts.
I'd be happy to chime in to offer something that actually might not provide additional clarification, but just highlight the muddiness. So especially if you're working in multi-level systems interventions, those distinctions become less and less clear, I think. And so I often find myself having conversations with colleagues who are, for instance, trying to implement a guideline, and they're talking about an intervention that includes things like audit and feedback that I might think about as an implementation strategy, but they're thinking about as core to their intervention to get this guideline going. And so I don't think the distinction is always clear, and it might not need to be made more clear, but the fact that you begin to think about these things, what is the set of interventions or the components of an intervention that are intended to deliver the immediate clinical or patient level outcome, and then stepping back from that a level, what are the things I'm trying to do to help get that to happen, can help us take the implementation science lens. Rinad, would you add?
Yeah, I mean, I think the answers you guys gave were great. If I were to kind of back it up all the way to try to give a black and white answer, which it's not, but if I sometimes am asked to do that by my students, they get frustrated with me and they say, just tell us, how do we know, what kind of trial it is really starting by looking at the outcomes. Now, of course, the points that Dr. Lewis just raised are very accurate once you start doing multi-level types of interventions. However, I do think that often folks will come to me and they're just interested in patient outcomes. And in that case, it's easier for me to say, without adding an emphasis on the implementation process, whether it be the barriers or facilitators or the strategies that you're using, it's easier to say what's not implementation science than sometimes what is implementation science.
Cool, thanks.
I think you're up, Rinad. Is that?
Yeah, fantastic. So I'm thrilled to have the opportunity to share a little bit of information with you all about a project that I did over 5 years. which represents a naturalistic observational study. I had the good fortune of being a part of a public mental health system that is very invested and continues to be very invested in use of evidence-based practice, particularly cognitive behavioral therapies that are psychosocial in nature. So this is a picture of the beautiful city of Philadelphia, where I'm lucky to live. Over the course of about a decade, our previous Commissioner of Mental Health, Dr. Arthur Evans, who sat at the helm of the Department of Behavioral Health and Intellectual Disability Services, was very interested in the question of how to get access to folks being served by the public mental health system, access to evidence-based practices. And this was especially salient to him given that many of the folks who developed the leading evidence-based practices, such as Dr. Aaron Beck and cognitive therapy, live here in Philadelphia and did that work here in Philadelphia. So various evidence-based practices that are all cognitive behavioral therapy in nature, and you don't need to worry about the details of each of the initiatives, but I share this so that you can see that over the course of about a decade, a number of evidence-based practices were rolled out, starting with cognitive therapy, followed by prolonged exposure, dialectical behavior therapy, and then parent-child interaction therapy. So again, these are all variants of types of cognitive behavioral therapy, and they were rolled out over the course of a decade. So at some point in the process of rolling out various evidence-based practices, Dr. Evans began to realize that the various initiatives that I just briefly described were somewhat siloed from one another, and we're not learning from one another, and we're facing similar stuck points in the process of implementation. And so he developed a center that represents a public academic collaboration called EPIC, which stands for the Evidence-Based Practice and Innovation Center, which was created really to bring together all of these various initiatives where evidence-based practices were being implemented across a large city serving over 100,000 consumers through the public mental health system annually. And what you can see here is a map of Philadelphia County, and each of these yellow stars represent an agency in the network that is implementing at least one of those evidence-based practices through the various initiatives that I described. So I want to be really clear, this study that I'm describing was very observational. So I personally was not manipulating any implementation strategies, and I think that taking advantage of these natural experiments where systems are implementing evidence-based practices can be very, very valuable. And I feel very lucky that I had the opportunity to do an observational study to understand how the implementation strategies undertaken by a system of care resulted in use of evidence-based practice. So this paper, led by Byron, actually describes the various ways that the City of Philadelphia supported evidence-based practices and included a range of training and consultation, contracting for evidence-based practice delivery, hosting events that highlight evidence-based practice champions, a newer designation process where organizations are designated as evidence-based practice agencies, and enhanced rates. So this represents the bundle of implementation strategies that were implemented by the system as part of EPIC, which is that larger kind of infrastructure, centralized infrastructure intended to support evidence-based practices in our city. Again, I'm not going to get into all of the details, but I just want to give you a brief sense of the data collection that we did in this project. So as I mentioned, 5 years. The first wave in 2013 preceded the creation of EPIC, and we were able to use Persist sampling to reach out to about 30 agencies that provided the bulk of services to children in the city of Philadelphia. And then again, we did continued sampling in 2015 and 2017. And over the course of our study, we're able to enroll about 500 therapists and 100 administrators to really get a sense of what happens to use of evidence-based practice over the course of the creation of this centralized infrastructure and all of these implementation strategies that were rolled out. And because it's very important to use an implementation science framework or some kind of framework in the design and carrying out of your study, we endeavored to do the same, and so we used a framework called the EPIS Framework, which was developed by Dr. Greg Ahrens and colleagues. It stands for Exploration, Preparation, Implementation, and Sustainment. This is a pre-staging, because we'll talk about this more in the next section. But briefly, this is a determinant framework, which means that it lists a number of contextual variables that may be of interest in the implementation process. So our primary research question was focused on whether a system-level policy or the creation of the centralized infrastructure would result in increased use of evidence-based practices, but we were also interested in the effect of contextual factors such as organizational culture and climate, implementation climate, and leadership on that process. So the main questions that we were interested in this case study that I'll try to pepper into the remaining sections when relevant is, does the use of cognitive behavioral therapy, which is the evidence-based practice that we were interested in, increase over the 5-year period as a result of the creation of the centralized infrastructure? What types of contextual factors drive clinician behavior in a large system implementing evidence-based practice? So again, our outcome was about clinician behavior. What are stakeholder perspectives on barriers and facilitators to implementation of evidence-based practice? So we got to use mixed methods to try to unpack that. And then we started getting very interested towards the tail end of this work in the temporal relationships between the various constructs, the contextual determinants, to try to understand mechanisms of the strategies that were used.
So the second study I will describe, I'll just offer a quick overview of a randomized trial where we compared 2 approaches to implementing measurement-based care in community mental health settings. And if you're interested, the full protocol has been published in Implementation Science. So measurement-based care is an evidence-based structure or framework for informing treatment. It's used for a variety of conditions across settings, sectors, and providers. Measurement-based care can be defined as the systematic evaluation of patient symptoms prior to or during a clinical encounter to inform treatment. And our team conceptualizes measurement-based care as having at least 3 core components to demonstrate fidelity, each of which adds incremental impact to the patient. So the first is administration of a measure. In most cases, that's a patient-reported outcome, but it could also be an objective measure. Following that, there is the review of data by the provider or care team and the patient. And then finally, a discussion of the data to inform care in that particular clinical encounter, and then in an ongoing fashion to inform treatment. And what we did as our primary aim was try to address this question of whether standardized or tailored measurement-based care implementation would impact clinician-level outcomes and client-level outcomes or patient-level outcomes. So we were interested both in the impact of tailored and standardized approaches on fidelity to measurement-based care, but then also on patient-level depression symptom outcomes in the case of our study, because it was the case that the measurement-based care intervention could be tailored to the clinic, and we were thinking that might change the impact measurement-based care otherwise is thought to have based on previous research. So this gives you a high-level overview of our study design. So it was a dynamic cluster randomized trial. Clinics were first randomized to, or they were matched first actually on based on size and then rural and urban status. Then they were randomized to cohort and then to condition. And we used a mixed method data collection approach at various time points. So these vertical lines are depicting assessment time points, bookending essentially the active implementation period and then a follow-up sustainment period. And then to appreciate the implementation intervention, it's quite a busy slide, so what I just want to draw your attention to is the fact that this first column indicates a set of contextual factors that were informed by a process model that I'll show you in a moment. And they gave us a sense of how we should design a blended implementation protocol of strategies to address each of these contextual factors or known determinants. And that in the case of the standardized implementation approach, we pulled together what we thought of as the best practices to address each of those determinants. And then in the case of the tailored focus, it was the content was contextualized, and this was highly collaborative. And so those were the main differences between conditions. And so we'll come back to each of these two studies throughout the talk, as Rinad indicated at the beginning, but just wanted to see if there's any immediate questions about either of those case studies.
Sure. So actually, given that we have likely a heterogeneous group in terms of their interests, you mentioned some wonderful examples that I think underscore the leadership of those of you and other mental health investigators in advancing implementation science. I wonder if you might have any other examples of outside of behavioral health that might also just explain the breadth of the kind of work that you've participated in or know of in the field.
Sure. We just got funding from PCORI to explore actually the impact of the EPIS model and the dynamic adaptation process on implementing shared decision-making for bariatric surgery in primary care settings. So that's an example case. Byron or Rinad, would you like to add others?
Yeah, sure. One of my favorite parts about being an implementation scientist is I get to learn lots of things about areas that I never imagined that I would learn about. I've had the fortunate opportunity of getting to work with some folks doing cancer care work here at the University of Pennsylvania. So this work has been led by Dr. Robbie Schnoll and Dr. Frank Leone, where they have been interested in trying to increase referral to evidence-based tobacco cessation treatment in patients with cancer. And so as part of this NCI-funded work, they created an automatic referral as part of the electronic health record for patients who endorse smoking as part of their cancer care to see if that would result in increased referral to evidence-based tobacco cessation treatments. And so that's been a really exciting project that I've been fortunate to be involved in.
And I'll just add, I've been really thrilled to have the opportunity to work with Rachel Gold, who has funding from NHLBI, to work with federally qualified health centers and to think about how can we better implement social needs screening within that setting. So she's really thinking through both the type of technical assistance that FQHCs need to implement social needs screening, as well as sort of how does that support need to be tailored. And it's a particularly interesting area because it's one in which I think this is not my area of expertise, but in which the social needs screening processes itself are not necessarily well defined, and different FQHCs may be implementing quite different interventions or things, if you will, depending on their specific needs and interests and resources available. So it's been fascinating to learn from Rachel and her team in that area.
Cool, and it just sounds like from each of your experiences and others that what we can learn about implementation across the different contexts, across different disease areas, will hopefully advance our understanding overall. So thanks for that.
Great. Okay, the next section is our entree into implementation frameworks. And so this has been probably an area of greatest proliferation and development for implementation science. As of 2012, there were over 60 implementation models, frameworks, theories identified in a systematic review led by Rachel Tabak and colleagues. This seems to be a favorite quote that Byron so gratefully identified the originating source. Frameworks do seem like toothbrushes where everyone has one and no one wants to use anyone else's. And so given that is the case, this proliferation actually creates a lot of confusion for folks new to the field. And so some commonalities could be helpful to draw here. So for instance, implementation does seem to be a multi-phased process. And so Rinad already mentioned the EPIS model that Greg Ahrens and colleagues developed, which suggests that there are at least 4 stages to implementation. Exploration is typically followed by an adoption decision. And I will say I feel like that particular phase is understudied, and oftentimes people seem to come to us, us being implementation scientists, having already decided on an evidence-based practice. So I think that's sort of interesting in an understudied phase. The next phase is preparation, after which you see this sort of active implementation work, such as training and coaching beginning, leading through the implementation phase, after which you really hope to see that the evidence-based practice is delivered with fidelity, and then sustainment phase following that. Just because these are ordered linearly doesn't mean you wait till the fourth phase to think about sustainment. Importantly, that should be considered even before you've decided which evidence-based practice you'd like to have implemented. The other commonality we wish to draw is that implementation is inherently multi-level. So across models and frameworks, we see that the individual receiving the evidence-based practice is impacted, but so is the team, the clinic, the organization, and the system, and so on. And different authors depict these levels differently. And oftentimes, knowing the target level can help you choose implementation strategies, which we'll talk about in a little bit. I'm really grateful for this paper by Per Nelson, who offers a typology of theories and frameworks and models, and helps us understand the difference between these and when each might be most useful. And so we won't take a magnifying glass to each of these types, but we will drill down into several of these types of models and frameworks today and talk about why you would use one versus the other and how that shakes out. So the first set is implementation process models. These are quite common, I think, especially among implementation practitioners, so people doing the hard work of implementation, and maybe less common in some empirical trials when trying to assess determinants and choose strategies, and you'll see why as we unpack each of these types. But just to give you a nice example of one process model coming out of Canada, where they're using the language of knowledge translation as an umbrella term under which falls dissemination and implementation. This KTA, knowledge to action cycle, is a widely used one by Graham and colleagues, published in 2006. And then one that I've used, it's kind of a hybrid process / determinant / evaluation model, but I think because of its limited specificity, I think of it more as a process model. So we use this in the randomized trial that I just presented on moments ago. Over here in the top left, you see that context of diffusion. So these are 6 buckets of contextual factors that are typically influential in an implementation process, and that they should be considered, and they will impact these 3 stages of diffusion or phases of implementation. And then throughout that work, you'll be paying attention to patient care, health outcomes, and organization and system outcomes. And the process that you might undertake to successfully move through these stages or phases would be beginning with a capacity or needs assessment, conducting process evaluations and providing formative feedback to inform future stages, and then a summative feedback process for the outcome or impact evaluation. I think at this point we have another break for questions, if you have any, David.
Thanks for asking. I do have a question. A lot of people come up to us and ask us, we know that it's important to have a model, but we don't really have a great sense of how we should go about choosing one. Any guidance that any of you have in terms of getting from that 61 or more models to the one that you would specifically choose for your study?
It's a great question. The first thing that comes to mind is the work of Russ Glasgow, Borshika Ravine, and colleagues in Colorado, where they have a website that is actually laying out the 60-plus frameworks and organizing them for interested users. And you can go to this website and essentially, knowing the parameters of your study or your project, you can begin to specify within the website things you might be interested in, and it can help you actually choose your model. I think the other thing I would say is that as we go through the next types of models, that the response to that will become more clear. But before we move on, Rinad, do you want to add, and then Byron?
So I think for me, it's very much driven by what my research question is. And so I've used various models that differ across projects based on what kind of fits the research question most appropriately. And I can talk about that a little bit more once we have all the frameworks kind of laid out. But I think that seminal paper that Cara described in 2015 by Nelson really did us a favor of the field by grouping the different types of frameworks into those three categories, because each of them serves a particular function. And so often I'll find myself using both a determinants theory and an evaluation framework together. And so I think being really clear about what you need your framework for and how it fits into your research question really helps me guide selection.
Yeah, just two additional thoughts. First, I would echo, I really find that Nielsen paper very helpful, and increasingly using multiple frameworks, which kind of complicates things for write-ups and both grant proposals and manuscripts. But I think being very clear, as Rinad suggested, is really important. And then second, I would point to some work that we've done. Sarah Birkin has led some work to develop a theory and framework selection tool. It's not rolling off my tongue right now, but TCAST. And so we sort of laid out some different criteria that you might want to consider in sort of four broad categories: usability, testability, applicability, and acceptability. And so there's an open access paper in implementation science. If that's not in our resource guide, we can certainly add that.
Great, thanks.
So now we'll spend a little bit of time talking about determinants and identifying and prioritizing barriers and facilitators. So you've probably already heard it in the language, in the way that we've been describing, that there's lots of words for determinants. These are broadly factors that might prevent or enable improvements in practice. And you can see here on the slide all of the different words that people use. I also, and Cara, when she was speaking, referred to contextual factors. From my perspective, this kind of all comes down to context. So just to take a step back for a moment, picture yourself as the principal investigator of a multi-site randomized controlled trial. That's an efficacy trial. Let's say that you start to identify significant site differences in the effectiveness of whatever intervention or efficaciousness of your intervention. That is something that's going to keep you up at night, that you're going to try to minimize all the noise that comes along from being context. So in implementation science, instead of seeing context as noise, we're really interested in understanding it and characterizing it, and there's a very growing sense that context is critical. And that's really what we spend a lot of time focusing on in implementation science. And so there has been a lot of work to date to really try to understand the determinants or the barriers and the facilitators of the implementation process. And there's many ways that you could assess for barriers and facilitators. Some of them are listed here. You could go to the literature and see what's been done already. There's no, sense in inventing the wheel if there's already been a pretty in-depth contextual inquiry of the particular setting and intervention you're trying to implement. You can use informal consultation, survey, interviews, ethnographic methods, and increasingly I think that the gold standard is to use mixed methods approaches in trying to characterize context and understand barriers and facilitators. I would say that one of the most robust areas within the field are these determinant frameworks, or these contextual frameworks, which basically provide a list of the various contextual factors that you may want to consider during an implementation process. One crowd fan favorite is the Consolidated Framework for Implementation Research, which was developed by Laura Damschroeder and colleagues. And one of the really nice things about the CFR is that it consolidates across a number of theories and frameworks from multiple disciplines to provide this consolidated framework. And lists 39 constructs within 5 domains, so these broad kind of buckets, including the implementation process, the individuals involved in the implementation process, the characteristics of the intervention, the inner setting, which refers to the kind of organization or the setting in which you're trying to implement, and then the outer setting, which refers to the broader socio-political context. And actually, CFR has a really wonderful website that's kind of constantly evolving. cferguide.org, where you can kind of see the latest and greatest thinking in the Consolidated Framework for Implementation Research. It's been a great addition to the field, and Laura continues to kind of push the envelope in thinking about how to use the CFR in guiding implementation strategy selection. One thing that can be a little bit overwhelming for folks newer to implementation science is knowing which of these constructs to prioritize, because it's 39 and much, much more than that. And the other challenge, I think, to the growing list of determinants frameworks is that there's no specific causal relationships specified between the various contextual factors, which can be really hard when you're trying to move towards a mechanistic understanding of how implementation works. Another framework, the Theoretical Domains Framework, is another example of a determinant framework. I would say that TDF, which was developed by Susan Mickey and colleagues, and there's a second iteration that has since been published, I believe, in Implementation Science as well, is more focused on the individuals doing the implementation, whereas CFR includes more of an emphasis on some of the organizational and outer setting factors involved in the implementation process. So you can see here, again, a number of domains which TDF suggests that you consider about the individuals involved in the implementation process, such as their knowledge, their skills, their intention, their goals that might impact their ability to carry out implementation. Yet a third determinant framework, EPIS, which we've already described before, is the one that I selected in the project and the case study that I described earlier in this presentation. And as Cara alluded to and mentioned, the really wonderful thing about the EPIS is that it acknowledges the multi-level process of the implementation process, and that there might be different contextual factors that are important in each of those stages. I personally selected this framework to guide the observational work that I presented on earlier because it was initially developed for public service sectors, and so it has a careful eye towards the contextual factors that might be important for public service sectors, and the work that I was describing was in a public mental health system, so it was particularly appropriate. I'll just close this section by noting that I think there's been a bit of an evolution in our thinking in implementation science, where earlier on there was a real focus in trying to capture context and a lot of work identifying the barriers and facilitators of implementation, both qualitatively and also increasingly quantitatively. And now there's an increasing interest in understanding the relationships between those lists of contextual factors listed in the determinant frameworks. So we just share this paper as an example of a paper that endeavored to seek an understanding of the relationship between molar organizational climate, or this kind of general organizational construct which refers to shared perceptions of how the work environment impacts the psychological well-being of the employees, and then strategic implementation climate, which is much more proximal to implementation and refers to the general sense of whether or not an evidence-based practice is expected, supported, and rewarded in an environment. And so longitudinally, in that case study that we've been talking about, we were able to look at the interaction between that general organizational construct and the more proximal specific implementation construct. And we were able to see that they were both very important. So in organizations that had high molar climate at baseline and high implementation climate, we saw increased use of evidence-based practice over time. Whereas in those organizations with lower general molar organizational climate, we saw no such relationship. So it's a really exciting time to be thinking about a mechanistic agenda, and Cara Lewis is definitely leading the way and helping us think through how to start elucidating those mechanisms. So I'm going to pause here and ask David if he has any questions.
Sure, I actually do. So as you look across the different models, we often see so many different barriers or facilitators that are listed. And it strikes us that it can be hard to try and identify which of those many barriers and facilitators are important within the context of any particular study. How do you prioritize among what could be a pretty long list of those different barriers and facilitators?
It's such a great question, and I can't tell you that I have the answer because I think as a field, we're still trying to figure that out. In some of the work that I've been doing, I've been applying a method called intervention mapping, which involves a review of the literature, also stakeholder input and expert input into trying to prioritize which determinants to target with our implementation strategies, and I found it to be a useful approach. But I do think that it can be difficult to know which determinants are most important, and sometimes we hear from our stakeholders, and we haven't really talked about this, but we will in subsequent sections, the importance of the stakeholder voice in the implementation process. I think as a science, we're still figuring out how, if stakeholders feel a particular determinant is very important, will that bear out empirically? And so I'm still struggling myself with figuring out what to prioritize and how to prioritize. But intervention mapping has been a helpful way to start thinking about that for me.
So I think Rinad touched on some things that are interesting also with respect to timing of when we assess barriers. So I think that comes out in two ways. One is sort of in terms of stakeholder perception. Sometimes we might assess barriers before an intervention is introduced. And so what we end up with is sort of perceived barriers and not necessarily real or experienced determinants of implementation. And another thing I think with respect to timing that's interesting and coming up increasingly, I think, as we think about tailored implementation is, rather than thinking about assessing barriers at the beginning of a project and at the end of the project, can we develop ways to iteratively assess barriers and adaptively address them over time, knowing that different determinants might be more or less relevant across different phases of implementation, and in fact, even addressing certain barriers may actually reveal a whole new set of problems that we hadn't anticipated. And so we've been trying to think in that area more, and I'm working with someone, Sobia Khan at the University of Toronto, to think about sort of how we can more systematically assess barriers and sort of addressing this notion that the question of how and when we assess barriers is not necessarily passé and not sort of figured out yet by the field. So hopefully we can push the envelope in that space a little bit.
I would just add a couple of things. One, that it seemed like the first bolus of work that came out of this generation of implementation science was, what are the barriers and facilitators? And I mention that just because I think that we're sitting on top of a pretty robust literature across a variety of evidence-based practices and settings and sectors and things like that from which we should draw. So I know Rinad mentioned that in her response, that intervention mapping has encourages looking to the literature, and I just wanted to underscore that, start there. The other thing is, I think this also came out with what you said, Rinad, but to underscore again, the intervention itself would highlight or point toward probable barriers and also strategies that should be brought to bear. And then I think that where there's real important methodologic work needed is, once you've done your systematic assessment of barriers, is this prioritization space? And Rinad noted that stakeholders might have opinions about this, but I get concerned if we just prioritize barriers that are perceived to be important and feasible by our partners, we might actually miss those that are critical to the implementation success based on, for example, theory. So I think bringing to bear our best knowledge theoretically and also from our partners and figuring out a systematic way to then prioritize the outputs from the barriers assessment is important work for the field to tackle.
Great, thanks.
So moving on to implementation strategies, or as we already mentioned, sort of the how of implementation. We've defined implementation strategies as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. And in our work, we've differentiated between different types of implementation strategies. So we often refer to discrete implementation strategies, which we define as single actions or processes used to enhance implementation. So these are things like reminders, audit and feedback, clinical supervision, a training workshop, and the like. Often given the myriad of barriers that we face in implementation, many of which Rinad just highlighted, we need multifaceted implementation strategies and sometimes even multi-level implementation strategies to address them. So multifaceted strategies that combine multiple discrete strategies. Also note here that some of these strategies have actually been protocolized, branded, and tested using rigorous trials. So a couple examples that I frequently give are Charles Glisson's availability, responsiveness, and continuity intervention, which is really designed to improve children's mental health services and implementation and clinical outcomes in children's mental health services through improving organizational culture and climate. Another example, we've mentioned Greg Aaron's work in relation to EPIS. Greg has developed a leadership and organizational change intervention that really targets specific leadership behaviors that we think are related to improving implementation and clinical outcomes. So some of these more complex implementation strategies are actually combinations of discrete strategies that are protocolized and tested as a package. This is a number of years ago now, we published from a structured review of the literature, a compilation of discrete strategies. And so we originally turned to the literature to ask the question, which strategies are effective for implementing evidence-based practices, and maybe more specifically, what are the evidence-based strategies? And when we first went about that task, one of the things that we found was just that the literature itself is a bit of a mess, that people use the same term to describe very different strategies, or use different terms to describe basically the same strategy, and that it was very inconsistent across different published articles. And so we sought to consolidate that literature a bit and at least provide terms and definitions for these implementation strategies that hopefully we could have some level of agreement on as a field. And this has sort of been an ongoing process. In that paper, we categorized strategies into these 6 different broad categories. So some of these strategies focused on planning, some education, some financing, some restructuring, either the physical environment or clinical teams and the like. Some focused on quality management or quality improvement drawn from that literature, and a few focused on attending to the policy context. And the idea here was that we wanted to give people a compendium of strategies that they could use in practice as they were designing improvement and implementation efforts, or to individuals and groups who were designing implementation trials, so they could clearly define the component implementation strategies that they were using. So based on the results of that systematic review, we were approached by colleagues from the VA, so Joanne Kirchner and Tom Waltz, who led this expert recommendations for implementing change study. And the first step of that study was actually to vet these terms and definitions from the original paper by a group of implementation practice and research experts. And so we engaged first in a 3-round Delphi process, and then later a concept mapping study, which basically allowed us to vet these strategies and come out with a refined compilation, and then categorize the 73 implementation strategies into distinct categories. And those are both open access publications. And I would just note that the sort of the most complete version of strategies and definitions is actually hidden in the additional file of that 2015 publication, if you want to track it down. So that work actually doesn't explicitly reference the evidence for implementation strategies, but we wanted to note that there's really a growing body of evidence for specific strategies. The Cochrane Effective Practice and Organization of Care Group, or EPOC, has really been a leader in this regard. And I won't go over these strategies one by one, but this gives you a sense that for some of these strategies, we actually have a great deal of evidence, and at least a great deal of a great number of trials where they've been tested. And I think audit and feedback, which Cara mentioned earlier, were actually auditing and measuring performance and feeding it back, often in comparison to peers, has 140 randomized trials, but there are still international efforts ongoing to actually optimize audit and feedback. So despite this growing evidence, we still have a lot to learn about, when, where, how, and why these strategies are actually effective. So given that sort of the evidence base is imperfect and we have this compendium of implementation strategies, how do we actually design and tailor implementation strategies so that they're effective? And this is perhaps an overly simplistic way of thinking about this, but this is an example where we would hope that as we do our context assessments and we identify potential determinants or barriers and facilitators, that our implementation strategies would be well matched to address them. So for instance, if we identify lack of knowledge as a problem, it may be appropriate that we have some sort of interactive education session to address that. If there's a perception reality mismatch, so maybe clinicians say that we're already doing evidence-based practices, we may actually want to assess whether that's the case by administering a fidelity measure and feeding that back to them in comparison to their peers. If there's a lack of motivation, it may be that we need to develop some sort of incentive structure to address that, and so on and so forth. And so this slide demonstrates how we might think of a single determinant being addressed by a single strategy. Oftentimes we know that this is more complex. We might have multiple strategies that address a single determinant. We also might have one strategy that addresses multiple determinants. And so this is just another perhaps simple example, but demonstrating how we might construct multi-level strategies. And this is drawn from a great paper by Brian Weiner called In Search of Synergy, published in 2012. And he's here pointing to multiple types of interventions that hopefully will address physician motivation and women's knowledge, and also improve provider-patient interaction. So in this case, he has a healthcare collaborative, which we can think of as an organizational level intervention, and a strategy to address provider communication at the interpersonal level, and then education and counseling for women, which we can think of as an intrapersonal level intervention, all of which, again, hopefully improve physicians' motivation, women's knowledge, improve the provider-patient interaction, and ultimately enhance cervical cancer screening rates. So typically, we're putting together discrete strategies into multi-level or multifaceted strategies, and hopefully we have some sort of model about how and why they're supposed to work, which we'll talk about in a few slides. So this slide, I guess, is fair warning. This might seem like we're beating up on the field too much. This is I think reflects our growth as a field and also the uncertainty of the evidence base and some of our theories, models, and frameworks in guiding this work. But unfortunately, rather than sort of systematically developing and applying implementation strategies, we often engage in these other ways of working. One of which is the train and pray or train and hope approach, in which we send clinicians and other stakeholders to training, and we hope that their behavior changes. We know from a robust body of literature that that's probably necessary but not sufficient to change implementation and clinical outcomes. Another, again, perhaps too pejorative way of saying this is that we often rely upon the kitchen sink approach, which is that we throw multiple implementation strategies at a problem, thinking that sort of more intense is better or more is better. And actually, there's some interesting findings in the literature that suggest that this is not the case, that multifaceted strategies are not necessarily inherently better than single component strategies. So referencing Janet Squire's work here from 2014. And there are a couple of plausible explanations for this. One is that we might not always have a great a priori rationale for why we're using multiple strategies, and they may actually not be very well matched to the determinants in a given setting. And another plausible example is that sometimes multifaceted strategies may be sort of multifaceted by definition, but they actually may sort of focus primarily on the same determinant or targets. So for instance, we might have a multifaceted strategy that really just focuses on improving provider knowledge and might not address other determinants at different levels, such as the organizational context, or the outer setting, financing, political factors that may actually influence implementation heavily. One might argue that we often also use the one-size-fits-all approach too often, that we think about implementing a specific intervention and we develop implementation strategies that might be common across different settings and systems when we know that these are actually highly heterogeneous and may need more tailored approaches. Admittedly, this is an area of ongoing work and debate in the field. How highly do we need, or how much do we actually need to tailor our implementation strategies to specific contexts? And then finally, my personal favorite from Martin Eccles, who is one of the original editors of implementation science, says that we often are driven by the Islagiat principle, or it seemed like a good idea at the time. And I think this often looks like inertia. Sometimes organizations and systems might say we've always done this way, and so we'll kind of continue to use the same implementation strategies. Other times we're really actually earnestly trying our best, but just don't necessarily have the evidence, theory, or systematic processes needed to implement well. So Rinad, Cara, and I and others have recently published this paper in Frontiers in Public Health, where we talk about a number of ways in which we think that we need to enhance the impact of implementation strategies. And I'm just going to hit on each of these quickly. The first is sort of building off of that previous slide of the sort of maybe unsystematic ways in which we've thought about applying implementation strategies, is that we really need more work to enhance methods for designing and tailoring implementation strategies. And that starts with what Rinad touched on, and what we talked about during that Q&A session, is that we actually need better methods for identifying and prioritizing barriers. And that's, I think, a really important area that we've already highlighted. We need more adaptive approaches. Again, barriers changing over time across the course of implementation efforts. So how can we assess those in an ongoing way and then adapt or tailor our implementation strategies accordingly? And then finally, once we've sort of identified the determinants that we think are key, what are some systematic and rigorous methods that we can use to enhance the link between the barriers and strategies? Because there's actually some literature to suggest that even when we try to prospectively tailor implementation strategies, we often end up with a mismatch between the types of determinants that we're identifying and the types of strategies that we're using. So for instance, Bosch et al. Found that we often identify organizational level factors that may be influencing implementation, but then we respond by providing sort of more provider training or individual level interventions that don't address those structural issues very well. So as we think about enhancing methods for designing and tailoring, we certainly think that this should involve participatory processes. As Rinad noted, sort of the centrality of stakeholder engagement in implementation science. Hopefully we're drawing upon the best of our theory to the extent that that's helpful, and hopefully we're not only drawing upon the best of our theory, but doing work that would build theory over time. To the extent possible, drawing upon available evidence. So again, relying upon the Cochrane Group and others who have provided excellent systematic reviews and meta-analyses of a number of implementation strategies, and building on that work and hopefully optimizing strategies over time, and really developing a thorough understanding of context before we go about implementing or selecting implementation strategies. So Heather Cahoon at the University of Toronto has a really nice systematic review focusing on different methods for designing interventions, specifically related to changing healthcare professional behavior. We've also suggested several methods that could be used to more systematically design and tailor implementation strategies. Rinad has already mentioned intervention mapping as a promising candidate strategy there that's gaining increasing traction in the field. So a second priority for us is really specifying and testing mechanisms. And so here we're thinking about not just whether or not strategies work, but how and why they work. So this is drawn from a paper that Cara and colleagues just published in Frontiers in Public Health. And here again, using the example from measurement-based care of wanting to increase depression screening. So our distal and proximal outcomes are actually related to screening. we might think of a financial disincentive for missing PHQ-9s as a potential implementation strategy. But here we're really trying to get people to specify what is that addressing. So in this case, the effect of that intervention might be mediated through clinician motivation, and we want to think through the potential moderators and preconditions that may influence the ability of that implementation strategy to take effect. So what is the value of the disincentive? Is this something that organizations and systems actually have the ability to change? Is this a policy that they have control over? Is the communication infrastructure in place to which that increased motivation can actually lead to increased screening?
So we were fortunate to receive AHRQ funding in late 2018 to host a 3-year conference series in partnership with CIRC, the Society for Implementation Research Collaboration. There are 2 aims that will guide our work. The first being to generate a research agenda for studying implementation mechanisms that has inputs from empirical work that has been conducted from our policy and practice stakeholders. And the second aim is to then disseminate that research agenda. And we will accomplish this important work through the convening of 4 work groups. So you can see the 4 work groups on your screen, and we have fantastic co-leads of these work groups. And then the blurry map illustrates what we're calling a mechanisms network of expertise that started off as a US-based group of individuals who will populate the work groups, but we're currently growing that internationally. And our first face-to-face meeting will be, as I said, in partnership with CIRC at the 2019 meeting here in Seattle, September 12th through 14th. And then we'll meet again in 2020 just as a mechanisms network of expertise to really flesh out that research agenda. And then in 2021, we'll disseminate through CIRC and other mediums. So we invite you to join us if you're interested.
Great, thank you, Cara. And just to sort of wrap up this section, so whether we're formally modeling the mechanisms of implementation strategies or not, we're really trying to encourage people to, whether it's by the type of modeling that I showed on the previous slide, or through more traditional logic models where we're talking about how and why our implementation strategies are working. Hopefully we're increasingly doing that so that we can accumulate evidence over time. We also think that we need a lot more effectiveness research. As I mentioned, the evidence is growing, but we still need to learn a lot about different discrete strategies. We need to diversify the types of strategies tested. So for instance, doing more at the organizational, system, and patient level within implementation science. And then we need more comparative studies. So for discrete strategies, how can these sort of discrete or single component strategies be optimized? For multifaceted strategies, we're increasingly seeing innovative designs such as sequential multiple assignment randomized trials, where we're thinking about what is the sequencing of implementation strategies, and how can we sort of start with lower resource implementation strategies and then adaptively apply more intensive approaches as needed. And then there's a lot that we have to learn about tailored implementation strategies, as I mentioned previously. So first of all, are tailored implementation strategies more effective than standard approaches? If so, how can we develop efficient and systematic approaches to tailor more effectively? We also think that there's a need for the utilization of a wider range of designs and methods. And so we conducted a review led by Steph Mazuka at Washington University in St. Louis, where we found that certainly, RCTs and cluster RCTs were the most common type of design used within implementation science study protocols. But there's also a wide range of designs and methods that we might apply within implementation strategy studies, particularly as RCTs are not always maybe ethical or feasible. Hendrix Brown and his colleagues have done a lot of great work to highlight those experimental and quasi-experimental designs, and would urge you to take a look at those as you're considering different possibilities within your setting. So we also have a lot to learn about economic evaluations within implementation strategies. And so this is actually an old paper. There's actually a more recent paper just published, I think, in the last couple of weeks that more or less replicated this finding. But in a review of 235 implementation studies, only 10% provided information about implementation costs, which obviously severely inhibits our decision-making with regard to which strategies might be most feasible within an organization or a system. And so we need to increasingly think about costs as we're thinking about our implementation strategy studies. We'd highlight some practical tools that have been developed. So Lisa Saldana has developed the cost of implementing new strategies approach, which couples nicely with some work that she's done to really document the different stages of implementation. But we need a lot more work in this front and potentially common frameworks for facilitating comparability across different economic evaluations of implementation strategies. Just as this first figure is just to illustrate that, surprise, surprise, implementation takes a lot of time and a lot of different implementation strategies often. So as we've tracked implementation strategies over in research studies or in real-world implementation efforts, we find that it takes a lot of person hours and a lot of different strategies, and we really need to do a better job of capturing that so that we can build in those costs in implementation efforts, and hopefully we can account for those resources. And also just wanted to mention Todd Wagner and colleagues at the Health Economics Resource Center associated with the Department of Veterans Affairs is starting to lead a work group around economic evaluation and implementation science, and eager to see what that group develops. And then finally, one of the challenges in implementation science, I mentioned sort of the challenges with language. Another challenge is that we often have poorly described strategies, and so we're not doing a good job of first tracking and documenting what we're doing in implementation, and then describing it clearly within the published literature, which obviously limits replication in science and practice, and really ultimately precludes many of these answers to many of these questions we're pointing to with respect to examining mechanisms. So we don't understand how and why these strategies work. Fortunately, a number of reporting guidelines exist, and I'm going to highlight one of them here that Enola Proctor, Curtis McMillan, and I have developed, where we really call for people to carefully name implementation strategies, hopefully in ways that are consistent with published guidance. So whether it's the ERIC compilation that I mentioned, or oftentimes people use the behavior change technique taxonomy or other published taxonomies within the field of implementation science to name a specific strategy, really carefully defining it, and then really perhaps more importantly specifying it according to who are the actors involved, what are the specific actions that they're actually taking, what are they targeting? This is another way maybe of thinking about the mechanism, but the specific action target that the strategy is meant to address. Thinking about the temporality or timing or sequencing of how these strategies are put together. So in some cases, we may actually need to, for instance, increase provider motivation before we send them to training. So increasing motivation for to learn about a given EBP before we send them to training. Documenting that type of sequencing is something that we're pointing to here. And then what is the dose of the implementation strategy? What implementation outcomes is it really intended to improve? And finally, what is the empirical, theoretical, or pragmatic justification for choosing that specific strategy? So again, really being clear about why that strategy was chosen within the context of a given effort. And there's some practical examples of people applying these types of frameworks, and basically the intent here is not to be onerous, but to really increase our ability to replicate these strategies in research and practice. I think we have hopefully time for questions and discussion.
And a question being teed up as we speak. So you talked a lot about the different resources and the ability to really walk through how to specify the different implementation strategies. I wonder if any of you could give us a bit of an example as to how, within the context of a specific study, you thought about which implementation strategies to use in your specific work in that study? Any examples?
Go ahead, Rinad.
Sure. Yeah. So I can't draw a parallel to the study that I was talking about earlier, because as I described, it was very much an observational study where I got to watch what a system was doing and the strategies that they selected. But I can describe some of the work that we've been doing around hoping to implement firearm safety promotion interventions in pediatric primary care. So for that project, we did a 2-year contextual inquiry where we used mixed methods to try to understand barriers and facilitators, and we used intervention mapping to develop a menu of something like 9 or 10 implementation strategies. And we just sat down to write a grant to start testing the different implementation strategies, and to use all of them just felt very cumbersome. It kind of felt like what Byron described, like we were just going to use a kitchen sink approach, and that didn't feel like the best use of our resources. And so we really drilled deep into the theory to help guide the 4 strategies that we selected. And we're testing, hopefully, we will test them compared to implementation as usual, because which will have 2 of the strategies in the bigger package. Also because we don't want to, we want to test it to a real test condition. We don't want to end up in a situation where doing something is better than doing nothing. So that's kind of how we went about deciding. I don't think you need necessarily that 2-year process for every implementation study, but for the particular case that I'm talking about, there were some nuances to understanding how clinicians and community stakeholders might feel about doctors and nurses talking about firearm safety with parents that required a little more contextual inquiry.
I can add an example from a residential treatment setting with youth where once we, similar to Rinad, did a mixed methods contextual inquiry and prioritized barriers. So we drilled down from something like 76 barriers to a top 3, and then the list fell in rank order thereafter. We looked at the available strategies and matched them to the best of our ability based on thinking about their mechanisms and having conceptual alignment with the prioritized determinants, but also having experts rate the degree to which it was perceived that the strategy would have a critical impact on implementing the evidence-based practice with fidelity. And then we created these blueprints that walked across the different phases of implementation to organize the strategies in terms of temporality. Byron, were you going to add an example?
Yeah, not so much an example, just a comment that I think, both Cara and Rinad have done work like this too. I think increasingly I'm trying to think about developing and testing different methods that would accomplish exactly what you're asking us. How do we actually select these implementation strategies? So, how do we, for instance, apply intervention mapping within community context and get organizations to be able to use that to basically tailor implementation strategies to their specific needs. So just wanted to signal sort of a need for, the question you asked is of course a practical consideration for anyone implementing intervention and as well as researchers proposing studies, but there's also room, I think, for a lot of methodological development here, and hopefully we're pointing to the fact that we don't have this all figured out yet, and I think we need some creative and rigorous approaches to do this. So hopefully we have more and more people that are explicitly trying to answer that question through methods development.
Sounds like an recruitment for folks who are listening in to join enter the fray. Sorry, Rinad.
No, I was just going to share. This is so kind of hot off the press that I wasn't sure if I'd say it, but we are piloting the use of this method called best worst scaling, which is a type of approach to elicit stakeholder preference that's in the discrete choice experiment family, where we're basically forcing a choice. You give 8 or 9 strategies to a stakeholder and say which one is the best and which one is the worst. And then they have to pick, because in our previous work we've been using Likert scales, and everyone kind of likes everything and says everything's important, so it's been kind of hard for us to suss out what we really should be focusing on, at least from that community stakeholder lens. And so I'm really excited. We're doing this work as part of our NIMH Alacrity, and we've gotten a great response rate to a survey using it, and people have been sharing that they're really enjoying it. So hopefully in the next 6 months or so, we'll have some interesting results to share with the community about this best worst scaling approach.
I think that the general message here is just to have this intentionality as you go into this phase of the work, and there are different parameters that can inform how you approach the selection and tailoring. And I guess this makes sense, but at the time I was surprised when implementation practitioners were remarking on how the causal pathway diagramming, and Byron showed you a picture of that, was particularly useful in the selection process for them of strategies, because it just forces that intentionality to, instead of just going toward the implementation strategies you're used to doing, like we always do training, we always do audit and feedback, we always do learning collaboratives, thinking really carefully about how do they work and what are the barriers that we're faced with. So with that, I will have us switch gears. We're moving into the section on evaluating implementation efforts. So we'll kick this off with one of the most widely utilized evaluation frameworks, known as REAIM, Reach, Effectiveness, Adoption, Implementation, and Maintenance, by Russ Glasgow and colleagues. I think that the citation got removed from this slide, but there's just been an enormous amount of work applying the REAIM framework to hybrid and implementation studies, and there are some useful web-based resources as well. And then this framework was also shared earlier. This was by Proctor and colleagues, first in 2009 and then updated in 2011, differentiating implementation outcomes distinctly from service and patient outcomes. And so there are 8 implementation outcomes here. And there have been some efforts, including in the most recent edition of the Dissemination Implementation Research and Health book, edited by Kolditz, Brownson, and Proctor, in a measurement chapter there, to indicate in what phases of implementation these particular 8 outcomes are most salient, so to help point toward when you ought to be assessing each of these and then trying to draw some relationships between them. So there's some evidence that suggests that acceptability, feasibility, and appropriateness are predictors of adoption, for example. So in an exploration phase of work, you ought to be, or you might want to be, assessing acceptability, feasibility, and appropriateness, for example. And so in the measurement space, our team has done a lot of work that was started with SIRC, the Society for Implementation Research Collaboration, to try to wrap its arms around the quantitative measures of implementation outcomes and beyond. So we've actually tackled all of the CFR constructs as well, and we've just completed systematic reviews of all of the CFR constructs as of last week, and we're now finishing up an update to the measures that people are using to assess implementation outcomes. So in 2019, we'll be able to help the field through sharing of repositories to understand what measures are valid, reliable, and pragmatic for assessing implementation constructs and outcomes. And our team also, through an NIMH-funded R01, developed 3 new measures of implementation outcomes, and the citation is there for you. This has been mentioned several times throughout today, that there is a tendency toward bringing qualitative methods to bear in our implementation research, and mixed methods as well. There are really strategic reasons for using each of these approaches to complement or instead of quantitative approaches. And I really appreciate the taxonomy that Larry Palinkas and colleagues in your bottom left corner published in 2011, helping us think about structure, function, and processes for mixed methods work. because it indicates, for example, if there are no quantitative measures that exist or none that have evidence of reliability or validity, it might be absolutely appropriate to bring a qualitative method to bear, or perhaps you're using quantitative methods for the purpose of sampling to then use qualitative methods in a mixed methods approach to dive deeper and explore some of the constructs of interest. So hopefully what you're hearing in my description is that mixed methods really means that there's integration. It's not simply the use of quantitative and qualitative in the same study. It's an intentional integration of the two different methods. And then to help us further, there's been some really important work published around study design. So given the settings that we're naturally working in to explore implementation processes and outcomes, it's not always the case that we have the luxury of doing a 5-year randomized trial. And so we need to understand what other study designs are available to us that will allow us to address the implementation research questions that get us started. So I encourage you to look at these articles, for example, and others in your resource guide for help with that. In terms of study designs, perhaps one of the most pivotal pieces of work for our field was the offering by Jeff Curran and colleagues on hybrid trials. And so we'll break that down a little bit further here. Acknowledging that there is a lot of time between efficacy effectiveness in D&I studies, Curran and colleagues really honed in on this gap, this time between an effectiveness and D&I study, where effectiveness studies are indeed happening in the intended settings, often with the intended provider and the diverse range of patients that are being targeted, but still with incredible resources brought to bear and control of the contextual factors. And what they're suggesting is that maybe if we're conducting hybrid designs, hybrid effectiveness implementation studies, we can actually speed things up a little bit. So they articulated 3 types of hybrid studies that you can think about as sitting on this continuum from emphasizing effectiveness on the left to emphasizing implementation on the right. And sitting squarely in the middle are studies that have co-primary aims of implementation and effectiveness research foci. And so, Rinad, do you want to say a little bit about your P2I evaluation?
Absolutely. So we're going to bring it home now and try to put a bow on it and talk you through how we used evaluation frameworks in our 2 case studies. So I will briefly describe how I thought about evaluation for the naturalistic observational study that I did in the city of Philadelphia. So just as a reminder, I was very interested in the question of whether or not use of cognitive behavioral therapy, or the evidence-based practice that we were interested in, increased over the 5-year period in response to the creation of a centralized infrastructure at the system level. And so when thinking about the implementation outcome that I was kind of primarily interested in, it was really about use of CBT strategies. And I'm careful not to use the word fidelity, which has a particular meaning because we were looking across treatment strategies. And so in this particular study, we used self-reported use from clinicians of the strategies that they used with a representative client using a measure that is established in our field. And of course, there are limitations to using self-report when asking clinicians to describe what they did, but within the resource constraints of this particular study, that was what we were able to do. The second set of questions was related to which contextual factors were related to clinician behavior in a large system implementing evidence-based practice. And so because we were using the EPIS to guide our understanding of contextual factors, we drew the factors that we thought might be most important. And fortunately for these constructs, there were a number of existing measures that had kind of just been released at the time of the start of the study, particularly the implementation climate scale and the implementation leadership scale, which are measures that Greg Ahrens and Mark Earhart developed right around the time when we were rolling the study out. So we were able to use quantitative measures to capture a number of the determinants that we were interested in. And we were interested in looking at the relationship between those constructs and the primary outcome of interest, which was use of CBT strategies. And drawing on what Cara said, because mixed methods and qualitative evaluations are so critical in implementation science to give a richness to understand findings, we conducted qualitative interviews using the EPIS to guide the questions that we asked and also our coding scheme to understand stakeholder perspectives on barriers and facilitators to implementation.
Going back to the case study that I started us with, this was the first aim was to compare the effect of standardized versus tailored measurement-based care implementation on both clinician and client level outcomes. So inherent to the tailored condition, clinics were bringing tailored strategies to bear. So it was important for us to be able to capture that work and do so in a way that aligned with reporting recommendations. So we established a method, a coding method of implementation team meetings that could be used to capture and then report out on implementation strategies that were discussed and those that were deployed each month, so that we could then link to see if certain types of strategies or categories of strategies or number of strategies influenced fidelity to measurement-based care. And I encourage wherever possible, especially if you're able to validate these measures, to use administrative data. So data that's already being captured either by the electronic health record or for reporting purposes for policies or accreditation systems. And so we were fortunate to be able to embed the fidelity measures into the electronic health record. So the three elements of fidelity being administer a patient report measure, review the measure, and then discuss the scores were a mix of both objective data capture and self-report. So in this case, the administration of the patient health questionnaire depression severity measure, that was captured objectively with the patient scores. Review of the graph, so the score trajectories over time, was also objective. We could capture if a provider actually opened up the graph and took time to review it. And then the discussion and how it impacted treatment was a self-report question embedded into the progress note for the provider. And then from there, the second aim of our trial that I didn't introduce you to before was to identify contextual mediators of measurement-based care fidelity. And we hypothesized that in the case of tailored implementation, clinics would actually be improving contextual factors that would then improve measurement-based care fidelity, because they were actually trying to bring strategies to bear that would address contextual determinants as they went along with their implementation. Whereas in the standardized condition, it was so focused on implementing measurement-based care with fidelity, sort of the in-the-room fidelity, what the provider was doing with the patient, they weren't targeting their attention to these contextual factors. And so we thought that those factors would remain present and problematic in the standardized condition. So in the contextual factors that we were interested in looking at, we didn't always have quantitative measures that were available for administration to assess these constructs. In some cases we did, in other cases we didn't, and in other cases still it's simply not appropriate to be inquiring about people's attitudes, perceptions, or beliefs, but rather you're trying to get more objective data or data from a different source. And so we have a mix of qualitative and quantitative measures of these contextual factors. And that's all I'll say about the measurement-based care evaluation, and see if David would like to field or ask some questions that we can field.
Sure, I would love to. Thanks for the opportunity. You've said a lot about, within the context of these two studies and just overall, about how many different measures, how many different constructs might be useful. I'm wondering, from the perspective of somebody who might not consider themselves primarily focusing on implementation, how would you incorporate some of these evaluation methods into studies that might be earlier in the continuum, whether we're focusing on an efficacy trial or you mentioned hybrid effectiveness implementation. Are these the kind of things that you would envision being useful components of those earlier intervention studies?
So can you ask the question again? What components would be useful?
Yeah, so how might I, if I'm doing an effectiveness trial or even thinking about efficacy, how might I integrate some of these implementation science constructs, measures into my study? Should I? And how might I do that?
Yes, well, it depends on when you begin thinking about this and if you have the funding to do so. But I think it also depends on what you think the real empirical question is for the work that you're doing, of course. So some folks are just really going to be quite interested in understanding what got in the way of their intervention being delivered with fidelity or being scaled. And so you're, in that case, going to be exploring barriers and facilitators, and you might have a narrow set that you're focusing on because you have some hypotheses, predictions about what it will get in the way. I personally think at this point all effectiveness studies should be hybrid type 1s at the very least. And what that means in my perspective is that we're capturing implementation process information. What did you do to help the intervention get implemented? Because without that information, you'll essentially have to recreate the wheel if you find out that the intervention was effective to figure out then how to get it implemented. I welcome my colleagues to add to that response.
Not surprisingly, I agree completely with Cara and her response. I think I've been very excited to see how many folks who are interested in doing more traditional intervention, efficacy, and effectiveness work have been coming to me and asking me, how do I infuse some aspects of implementation science into my work? And I give them an answer that's very similar to what Cara said. I think even earlier in the pipeline, there is thinking around how to design for dissemination and implementation and making sure that your interventions are kind of going to be implementable when the time comes, and including stakeholders from day one and developing the interventions for the places in which they're meant to be implemented. So I also think there's a tremendous opportunity early on in the intervention development process to be thinking with an eye towards implementation, and I think that's really exciting.
We then have a list of other questions that we could consider. So advice for someone starting off in the field. My thinking would be that join some networks or get on some newsletters. So David, would you say something about the NCI network and what their offerings are?
Sure. I mean, we have a monthly newsletter. We have, we do a lot through social media at NCI IMBC is the Twitter handle, and are always trying to make sure that people are aware of recent upcoming papers or recently published papers, upcoming conferences. We do monthly webinars. And so folks can certainly follow up with me or our colleagues at NCI if they're interested in joining those lists.
So we have something, I hope I don't butcher the URL, but Implementation Science News, if you Google that, is an effort through the Consortium for Implementation Science, which is RTI International and UNC, and that's a great sort of collection of resources about training, publications, and the like. And the other thing that I'll add, just to, in addition to sort of networks, is there's really been just a ton of good webinars and other resources on the web. So the Prevention Science Methodology Group has a great series where they feature some really high-level methodological talks in implementation science, and the NCI group, the VA Cyber Seminar group has a lot of implementation-related webinars, and so there's really, I think, in recent years, more and more resources for people that are just starting out and want to kind of dip their toe in the water before they jump into some of the more intensive training institutes or formal coursework and the like. So I think that's a great thing.
I realize that I sort of jumped us to networking and connecting, but let's stay there. And Rinad, do you want to add the offerings through Penn?
I can, although I might answer this question a little bit differently. For me, I think the advice that I would give someone starting off in the field is really about seeking out informal and formal mentorship in the space. So I completely agree that all of these various resources are tremendous ways to quickly get up to speed on implementation science, what's been done, and what the future looks like. But speaking from my own personal experience, the way in which I think one kind of really goes all in, having both the formal opportunities that are offered through the NIH and various universities, and then, really apprenticing or working closely with an implementation science expert. There's no substitute for that.
Do you want to mention any of the Penn offerings, or should I?
Yeah, we have a 3-day deep dive implementation science institute that we offer annually, and each year we've been fortunate to have keynote speakers join us from the NCI. The first 2 years it was David. This year we have Wynn Norton joining us, and it's a really good way to kind of jump into the deep end of implementation science and terminology to kind of jumpstart, moving into that space.
And then I was going to add that through CIRC, the Society for Implementation Research Collaboration, there is a reading list for folks new to D&I in our initiatives tab on the website. And then in addition to that, CIRC members can join a network of expertise depending on their level of training and familiarity with implementation science. And so folks who might not have PI'd an R01, for example, in an implementation science way, they could get matched up with an expert network of expertise member for mentorship there, and it's free for CIRC members to obtain that. I feel like we addressed the first two. If folks are okay with that, I'll move on to how to build capacity at your institution. So my quick response would be to say my approach has been to be hosting journal clubs and engaging those with the energy and interest in proposal development and giving them pieces of implementation science proposals to lead or co-lead and then iterate with me. So that's a couple different ways that we've approached this. Byron, what would you say about this?
Yeah, so I mean, first of all, starting with the resources and infrastructure you already have. So many CTSAs now include, some sort of dissemination implementation research core or groups that are tasked with providing consultation around implementation science. And so there are a number of those groups at UNC and at WashU, and certainly Rinad will talk about what's available at Penn there. So I think working to do that sort of through the formal channels, I think there are a whole host of people that are interested in this area from across departments. I think the challenge is almost, bridging sort of those departmental and school divides, and sort of speaking the same language and doing some translational work to sort of identify the common areas of interest and problems that you're addressing. But I think there are all kinds of models for, as you mentioned, journal clubs, other sort of more flexible groups that are working on grant review, paper ideas, applied implementation efforts. And so I think there's a number of opportunities to plug into. And I guess I'd just add, this is sort of bouncing back to the other questions, but I found the implementation science community overall to be extraordinarily collaborative, generative, and just a friendly and fun group to hang out with. So I guess the piece of advice is don't be afraid to email people and reach out. If you're at a conference and you want to connect with someone, I think it's a really welcoming and fun group. So would welcome you to do that.
Rinad?
So yeah, I've been very fortunate to be at a university that has recognized the importance and the promise of the field of implementation science. So when I joined the faculty here, there was already the rumblings of 2 initiatives which have now kind of turned full-blown into an implementation science community. One was a working group that was convened by the Rinad Beidas Institute of Health Economics to bring together an implementation science community a little bit more informally, just in the types of meetings that you both have described, really focused around proposal development and technical assistance around implementation science proposals. And then the other is a course that was developed through our Master's in Health Policy. That's a semester-long course focused on implementation science in health and healthcare, which then gave birth to the Institute because there was so much demand for training in implementation science. So we now have a center. Those various initiatives have been turned into a center, the Penn Implementation Science Center, PISE, at the Rinad Beidas Institute. And it's really a beautiful thing to see the kind of community coming together. And like Byron described, you know, we have folks from surgery, psychiatry, internal medicine, and it's really organically evolved into a community of people who are really committed and passionate about reducing the research to practice gap and training the next generation of implementation scientists.
And if I can just add quickly, Rinad reminded me, so sort of the course structure, I think we're finding increasingly that we have need for sort of, you know, PhD level or more research focused classes, and probably increasingly more specialized classes focused on implementation science, as well as the need to train people that are going to be more implementation practitioners, so like MPH types or MSWs and the like, that might be doing this work and need to apply these skills, but may not be interested in the theories and methods as much.
Great. David, would you like to add anything to that question?
I guess the one thing I'd say is that each of the 3 of you are at institutions where there's been a reasonable amount of support for this work for a while. And if people are listening who may not necessarily see that as transparently at their institution, would encourage people to look beyond some of the verbiage. You know, so whether somebody is specifically laying down their, you know, sort of signpost as an implementation scientist, or is simply interested in understanding and trying to improve practice. I think there's been a lot of, as you know, was said as part of this training, a lot of different fields that have really been thinking about these issues for decades, in some cases centuries. And so I would look for other colleagues who are each maybe in disparate areas around health, or even, you know, other sort of social services, who are all interested in trying to understand how work is delivered, understand how quality care emerges, and understand what can we learn together about how to improve what's being offered to you know, people sort of across the lifespan in different social service agencies in health and in healthcare.
Great. I'm not sure we have time for the last question, so instead I would invite you to find us at the next D&I conference, and we can discuss over coffee. How does that sound, friends?
Sounds great.
Excellent. Good. David, do you want to wrap us up with any final thoughts?
So we started this out because we recognize that there's so much interest in the field, and there isn't always a freely accessible way for people to get oriented. And so we've been very appreciative of Cara, Rinad, and Byron's interest and willingness, not only at our last in-person conference, but to provide this training online, so that even if you can't make it to the 12th annual, which we'd love to see you at, you'd still be able to get a good orientation and hopefully find other like-minded folks to help us move the field forward. So my huge thanks to the 3 of you for spending the last couple hours with us, and for providing this kind of resource for anyone who wants it.
Our pleasure.
Thank you.
Thank you for having us.